I just listened to the whole message. I was trying to get the kids in bed, so I was.
No, I understand. I don't really understand YouTube and all, and I was afraid maybe I didn't do it right, so that's all I was.
Yeah, no, I got it.
Okay.
I just didn't. I felt like I shouldn't listen to it in front of the kids because I didn't want to get them.
Right, I
anyway.
understand.
All right, so first of all, whoever that doctor is sounds like he's a very good guy. He spent a lot. Sounds like he was very. I can tell when there's good. When somebody spends that time on the phone explaining things in the way he did, and is detail oriented as he was, he's a good. Seems like a good egg. His advice is absolutely spot on. You should not see Dr. Langer. This is why I've been emailing saying basically, we need the biopsy results. You can't make choosing an oncologist in this day and age. You have to know the pathology to know who the right oncologist is to see. So we know that, and I was worried that this would be what we'd find, even though the mass is in the lungs. There were two. My concern was it a recurrent hepatocellular carcinoma, or was it a lymphoma, which can occur in the lungs in somebody who's immunosuppressed after a transplant. And then of course it could be a primary lung cancer, but primary lung cancer almost never grows this quickly. To go from almost nothing to the size it is be kind of unusual. Given the choice between lymphoma and hepatocellular carcinoma, I don't know, it's sort of 6 of one, half dozen the other. I looked at both of these doctors. First of all, this is just my gut feeling, but when you have a complicated recurrent tumor and you're immunosuppressed, in that particular circumstance, you're better at a large academic oncology center. You're going to get better options, and you're far more likely to be able there's the possibility, for example, at a something like a Cooper program. I know they're affiliated with MD Anderson or whichever facility it is that they've signed on with. They may not be running the breadth of clinical trials at a place like Cooper that they would be at an academic center like Penn.
Yeah, we kind of decided we needed to go with Penn, mostly because Penn does liver transplants, and we need to be with a hospital that does them, and I don't...
That understands them and can manage it, because the real issue here is going to be managing the immunosuppression with whatever treatment is pursued.
But now my question is, do we go back to Jefferson or stay with Penn? We kind of wanted to just give a different hospital a chance, just because, I don't know. I didn't have a lot of great things. And also, Penn's a little closer. We didn't realize it till we went there, but, it's a little closer. The parking is a little cheaper. But, we need to be wherever the best is.
Yeah.
And I didn't know if you could research, what doctors are at Jeff, and then these two. I guess there's only two at Penn to choose from.
Right, and they both look very good. Their credentials are all excellent. So that Arturo he's an assistant professor. She's an associate professor. So she's a little bit older. She must have worked, let's see, when she finished she's certified in 96. She finished her training in 92, 02. So she's been doing it for 20 plus years. So she has great patient satisfaction ratings.
Mm-hmm.
She's only listed in her bio sketch that I can look up in our system where we can look up docs. She's listed like 8 or 9 publications. My suspicion is that she is the primary clinical doctor. So typically in this circumstance, it kind of doesn't matter which of these two that you see, because they probably both work very closely together as a team, and decisions on treatment are usually made, in a complicated case. It's sort of a group decision where they'll review the case together and then agree upon what is the recommended best course.
What you're thinking about the fact that you said that they're going to have to adjust the medicine, like his medicine, that's handled at Jefferson. Is that going to be an issue?
I don't think so. I think what they'll, for hepatocellular carcinoma that is outside of the liver, there are some new there are some depending on what the markers are. This is something that the pathology department will study at Penn. They will look at what the they're still doing, even though you get the pathology results today. That's really just the preliminary pathology results. I mean, it's the diagnostic results, but they're still testing.
Yeah, he told me that would come in a few more days.
Right. What is the they'll know what the receptors are on the tumor itself, and that can help determine which treatment it might best react to. There are some clinical trials testing new therapies. Immunotherapy is a targeted therapy that sort of tries to recruit the immune system to fight, essentially to kill the cancer on behalf of you. The problem with immunotherapy, and I just don't know the data on this, it's my guess is that in the context of being on an immune suppressant, it may not be as effective. There's a drug called sorafenib, which has actually shown some pretty good promise in not necessarily eliminating the tumor, but suppressing it.
Mm-hmm.
And I know I know from a patient that I was following at the VA that it has been used, and I'm pretty sure they actually moved this up right here. Efficacy following TACE or liver transplantation. Recurrent hepatocellular carcinoma after liver transplant. There was a study done in 26 patients who had this type of cancer after a transplant, who couldn't have surgical resection or local regional treatment, something TACE, and so they're saying this might be a feasible treatment option.
So you do think they're going to give it? See, what scares me the most is we just went to see his transplant doctor, and he said, just hope he said, I'm afraid that it might be liver cancer that metastasized there. And he said, the problem with that is there is no treatment for it. There's no chemo for it, and there's no radiation for it. And so he just painted a really bad picture if it came back to be liver cancer. So that's why.
I think it's a fair assessment. There is no standard of care treatment for it. In other words, if you come in, I'll give you an example. If you come in with a non-small cell lung cancer, which is a lung cancer itself, or there's certain types of cancers where we know if you look it up in any medical textbook or current medical recommendations, they're going to say the first line treatment that has been proven after extensive testing in the medical literature is X. You need to do this first. If that fails, then we have to figure out what to do. But so there's some cancers where there's a known and obvious first choice that is a no-brainer, that it's what you do, right? Mm-hmm. That is not the case here. There's no definitive treatment, and any treatment that is considered is going to have risks, potential benefits. There's no home run treatment, is what he's saying. But getting a recommendation from an academic, like somebody who does this on a regular basis and who's managed complicated cases, is worth it. I don't live in this world. I can read the database here. It's what some folks are saying can be done. But the right people to get the advice, it's exactly like the doctor on the YouTube call said, is the right people to do is you go to somebody who's a medical oncologist, they're essentially a chemotherapy and they're a medical doctor. Their primary tool is chemotherapy. They have a couple other tools in the tool chest, but and you say that who treats these kind of gastrointestinal or liver malignant disease, and that's all they do. And you see what they say.